what you guys are learning, okay? So pulmonary function testing in general, right, the main point is we're trying to get measurements, right, so we can see if something is abnormal, right? So we do pulmonary function testing, not on everyone, right, but if it's suspected that our patient's having any respiratory issues and we don't know why, pulmonary function could be warranted, okay? And so just going down the same order that your book's kind of breaking everything down. The main idea behind what they start with, right, is understanding these normal results compared to what you see in different disease processes. So the big idea, right, is understanding restrictive compared to obstructive compared to normal, okay? And so I think how I started with the last group is I just gave you some information, okay? So let's start with restriction. So I would just write down restriction equals loss of volume or low volume.
If you have signs and symptoms, been exposed, definitely follow all the factors. Get tested so we know. Okay?
Okay. Everyone good with that?
Mm-hmm.
Okay. If you want to just add one more bullet point under that for completion, right? Normal flows.
Also attending
Okay.
clinical sites if you do have any signs and symptoms or if you've been exposed. If you have any questions.
So you're going to get a lot of numbers, visual things from doing these tests. The big idea for this disease process, right, is you're going to recognize lower volumes than normal, but normal flows, okay? That's restriction, okay? Now, when we think of disease processes, okay, if it's not CBABE, it's restrictive. Does everyone know what I'm talking about?
Mm-hmm.
Everyone?
Can we go over that again? What is that?
Okay.
Acronym?
CBABE is the acronym for all of your obstructive processes. So cystic fibrosis.
But we do consider excessive lab absences as 2 days of lab. Clinical absences is 2 days or 6 days.
Let's say the B, chronic bronchitis. I know it's kind of not completely accurate, but A is asthma. The other B is bronchiectasis. And then what's the E at the very end? Emphysema, okay? So, in the next little part, when we get it obstructive, those are the diseases we're talking about, okay? If it's not on those, start thinking probably restriction, okay? Okay, so we said restriction, we're going to see low volumes, we're going to see normal flows. If it's not CBABE, it's probably going to be restrictive, okay? Let's go to obstructive now, okay? So obstructive, we're going to see, let's go ahead and put norm just to stay the same flow, normal or high volumes, okay?
Not participating in patient care, foul language.
And we're going to see decreased flows.
Not completing your Tyson documentation, not in uniform. Making sure that you have your.
And it's an increase in flow?
No, for obstructive, it's going to be a decrease in flow.
Decrease in
Yeah.
flow.
Especially since we're going out.
And so let's talk about that. Okay, well, let's talk about both of them for a second, okay? So with restriction, we said low volumes, okay? So how does that make sense? Why are these volumes low? If I was to,
These are your holidays.
kind of the easiest way to do this.
Last days are clinical days, which is February 18th and April 5th.
Okay, let's just say that's your volume, right? Okay, so right now, we
Here's your
have
forced outline.
gas in there, right?
So what are we looking at?
So when we think of restriction now, right, we lose volume. So whatever this equals,
You
we
get
lose
84%
it.
or less, you have to
And
repeat
so
the
if you
skills.
guys think
The
of
second score will be deducted by
atelectasis, right?
10% because you have to repeat the
This thing's
skills.
just,
And the second score will be
there's no
cleared in
volume,
Canvas.
right, compared to how big this is.
Your clinical
If you
evaluation,
think of-
just like last semester, are worth 40 points. Those are the evaluations for the preceptor.
Right, if this is all fluid and secretions and all that, well, then
We're
you only
there,
have
obviously there's nobody there. to
this amount of gas,
All
right?
right,
So
So your
anything
typing
where
pace
you
level and
lose
time log are both worth 10
volume
points.
in
This
any
includes
alveoli, right, you're gonna start
labs
losing volume overall.
days attended and
Cause you
classes.
lose the space.
Because you lose the
So,
space.
Okay.
clinical. So by the
And
end
so
of the
that's the
semester, you should
hallmark
have
of restriction,
time
right, is
spent
that you're gonna
on
start
pace
losing
level
volume.
and time level.
Okay? Now, when we think of obstruction, okay,
So today
What-
you're going to
why do we see decreased flows?
graduate college.
Why would the air going in and out of our body be decreased?
Because there's reduction in the airways, so the airflow isn't able to get into the alveoli.
Yep. So, write this down. We're not going to get into it right now, but do your best. Write down Google, right? So you can just talk into it. Hussway's law. Okay. Don't ask me how to spell it because I have to look at it every time. Hussway's law. Okay. But it's basically, and we will talk about it in our carry team, but it basically will break down all the different ways that you could see flow or pressure change. Okay, so it's very helpful once you can kind of understand it. But, so with obstruction, yes, right, our airway goes from big and somehow something, right, is making it smaller. And now air has to get through there, okay? And so with obstructive processes, all those CBABE diseases, right, it's going to be harder to get air in and out, okay? Now, once flow decreases, right, or gets trapped because of obstruction, what happens there? How does that lead to the other part in your notes? What do you guys think? We said volumes, right? What do we write about volumes and obstructive?
The alveoli become hyperinflated, so like they expand and they're not able to.
That's the website you
So,
guys use
right
to do
now-
your American Data profile, and that website houses everything for the entire clinical site of the Central Valley. So that's
Right,
our
so
portal that we use.
That's my bronchoconstriction or whatever, okay? So air comes in,
I also.
right, and then not only a little bit can get out, but you still have more coming in.
Individualized.
So this alveoli just starts
know that
getting
any
bigger and
hospital
bigger.
references,
And that's called
you guys can go to
hyperinflation. That's
SKD Next.
because of the air that's getting trapped being built up and built up.
Are there, and they have all
That's
of
what leads to, you guys have also heard like the barrel chest, right? So obstructive processes, when you think of PFT results, you can actually see higher than normal volumes for obstructive processes. Okay, and that's because of the air trapping.
who have clinical paperwork.
And so I'll give you guys a visual in your book. If you don't have your book, you can just write it down the table. This blue one right here is really good for kind of trying to give you a visual for recognizing these changes with the diseases. So when you look at the restrictive process, right, everything, the boxes are all smaller, right? That's that loss of volume. If you look at proportions on that table, the proportions are very, very similar to what the normal is, okay? It's just smaller, okay? And that's the hallmark. So even when you get to the actual visuals from doing your test, restrictive processes look just like normal, but smaller. Okay. Now, when you go to obstructive side, right, everything's bigger, and that's because it's due to that air trapping. Okay. And so when you see, again, patients with obstructive processes, and you get measurements from them, sometimes they're bigger than normal volumes. Okay. We'll come back and look at this in more detail in a second. But,
You want to turn in your preceptor evaluation weekly to me, that's great. You want to turn them in all at the same time, that's fine.
those are the basic big changes that you guys have to remember for spirometry and what you're looking for, okay? Because when you recognize those, now you can say, yes, we have a disease process, okay? We have a disease present, now we can start treating it correctly, okay? After that, your book gets into all of the different lung volumes and capacities. So, do you guys know all of them? Did you look them up? Anything like that yet?
Call me, you'll report it to me.
No,
And then
I don't know that yet. We started, you mean the ones that are right there?
These, yeah, these.
Okay, yeah, we started.
Okay, so what we have to kind of know for your lung volumes and capacity is simply that you're going to hear those words a lot, right? And for some reason, capacity always like throws students off. But capacity is just two or more volumes, okay? So we have different lung volumes, and then we have different combinations of those that make up different lung capacities, okay? So ones that are gonna be very important for you guys, well, let's just talk about them in general, okay? So what is tidal volume?
So, if you're
Normal
hospitalized,
breath in and out.
required, make sure you guys take your
Go ahead.
That's the
Always make
volume
sure you guys have a full badge.
Say it.
That's the
I think right now, the only hospitals that are requiring badges
Yep, so
are
normal, proper,
Kaiser,
quiet breathing, okay? Think of breathing just at rest, okay? So all of us right now, we're tidal breathing, okay? I brought it up with the last group, right? Like I tried to go jogging yesterday, my tidal volume changed, right? My respiratory rate changed, okay? And so, tidal volume's at rest, okay?
But just make sure you guys always take
What's
your
IRV?
badge. If for some reason you
Inspiratory, inspiratory reserve volume. Okay, unless I just made that up, it sounds good.
Sounds good.
It sounds good. Okay, now, one way, right? Practice this stuff, okay? I swear if you do it for 5 minutes, you'll never forget these, okay? Everyone, try to go to IRV right now. Try to breathe to IRV.
require you guys to
There it is, right?
Okay,
Okay, look.
That's
IRV. Okay, now go to ERV. Try to do that.
Now we're gonna.
Right? So breathe normal, and then after you normally exhale, keep trying to push yourself to exhale more, right? Wherever that stops, that's ERV. What's left over?
So maybe you guys already have done some of the things out there before.
It's called residual volume, okay? So that's what comes up with pulmonary function testing. Spirometry, the main one we're going to talk about, we can't measure residual volume, okay? Because we're basically measuring our patient from a maximum inhale all the way to a maximum exhale. That's all we're measuring. So that amount that's left over that we can't get to, we don't know, right? It's still unknown at this point. And then that will lead us, if we need to know that information, that'll lead us into lung volume testing, okay, which we can find out what volume that is, okay? We'll get there in a second. So,
Today, make sure you have at least a paragraph.
vital capacity, okay? So 2 capacities you kind of have to know about, okay? FRC, functional residual capacity,
I'm gonna put those pipes in, and I'm gonna make sure that everything.
okay? Now, if you look at your table, tell me what volumes, and you guys can use this book if you need it, but what volumes make up FRC?
Expiratory reserve volume and then the reserve volume.
Okay, expiratory reserve volume and residual volume. Okay, you always hear about FRC in the sense of they're like clinicians, RTs, they're like, how can we increase FRC? How can we maintain FRC? Okay, and so now, just remember that, okay? Remember the volumes that they're talking about. So after a normal exhale, whatever's left over, right? And so basically that's gas that helps keep our alveoli open, it helps participate in gas exchange, it helps with oxygenation. And so in a lot of your different textbooks and clinicals, you're always going to hear people talking about trying to increase or maintain FRC. That's what they're talking about, okay? That amount of gas that really helps participate in gas exchange, okay?
So this is just.
The other capacity that's really important to you guys is vital capacity, okay? So now look at your table again. What makes up vital capacity?
It's the same as, so the trend is.
Oh, sorry. Reserve volume.
One more.
Expiratory reserve volume.
Yep. So and now this was the challenge to the last group. How would you explain to a patient what you need them to do? What if I said, explain to your patient, you need to tell them how to do a vital capacity?
Inhale deeply.
Okay, hold on. Here's the temp one. What do you say? Go.
Breathe in or take a deep breath
Okay.
in all the way.
Okay.
And then you either slowly or exhale all the way. I don't know.
So the test we do is a forced vital capacity. There is a slow vital capacity too, but usually we just start with forced. So what do you think? Is it fast or slow? Fast, okay? So only thing I would kind of add on, right? If I was like explaining it to someone, be like, I need you to breathe in as deep as you possibly can until you can't breathe in anymore. Then I'm going to ask you to blow it out as hard and as fast as you can until I tell you to stop. Okay? And when you see people who are really good at this, like it's kind of fun because I had a guy, I don't know if he still does it at the VA, but he basically used to tell his patients like, he had this whole, I thought it was like a little script, but he just does this day to day to day, right? And so he was like, you're not allowed to pass out unless I tell you to pass out, right? And all these people are like, what? But that's what it was, because you really, when you think about the test in the simplest form, does the patient have to participate? Does the patient, do you think if they make a good effort or a bad effort, does it make a difference?
Yeah.
Absolutely, right? So this is really patient, you need to have them trying their best, right? And so that's why you guys become very important, because the better you are at coaching people and stuff, like they're gonna do better, okay? And you can get them treatment better. So vital capacity is important, okay? Maximum inhale to maximum exhale, that's going to be one of the main tests that you're going to do. It's called a forced vital capacity, okay? And it's done with spirometry, okay?
And this is the way they want you guys to submit your testing if it pertains to you. So it's your last name, the pharmacy, the school.
If you guys are really like, if numbers help you remember things and visualize things and like that, your table 4.2 gives you the average volume amount for each of the volumes, okay?
And make sure that you guys go with your N95. So what?
So,
Cities.
yeah, just if you like, so to know the numbers that go along with the different volumes, they're right here. Let's see.
Okay. So children, the deadline, the goal is February 1st.
Sorry, no.
All recommendations, vaccine boosters pursuant to the schedule.
What was the law that you
They actually have a
mentioned
chart.
earlier? You say that, don't ask you for spelling.
Oh, Pusway's law. No, it starts with a P. Yeah, it's like P.
Yes.
P.
S.
O.
P-O-U.
I-U-S-E. I don't know.
He's in the group book.
It's in all the books.
Yeah, it's in
all the
chapter
books.
6 of Egan's.
Oh, Egan, thank you.
Okay, yeah, chapter 6 for you. Yeah. In ours, I want to say it's probably chapter 11.
After 6 months.
Do you find it?
J&J is after 6 months.
Okay, so
Information.
I think at this point we kind of got into spirometry a little bit, but what I want to tell you guys first is kind of what the different things are that we're going to play with over the next week or so. Okay, so all of this stuff you kind of have to know a little bit because it's all on your board exam, right? Even if you like, I always tell people I have no interest in PFTs. Okay, I'm interested in it now because I find it fascinating and something, whatever. Like there's a specialty credential that you can get for it. But when I was a new graduate and stuff, I wanted to do the action stuff, right? So I was never interested in this. But you have to know because there's lots of questions on your board exam, okay? So what does this look like?
Syringe.
Syringe, okay? Name? It's actually what you might hear, yeah, well, like this.
Oh, okay.
Okay, so the name that you might hear referred to in the board exam is a super syringe. Okay, super syringe. Technical name, again, you might see a reference as this too. 3-liter calibration syringe. Okay. So with that name in mind, 3-liter calibration syringe, what do you think it's used for?
So you probably get it like Friday.
Sucking out air.
Something to do with PFTs.
Something, okay, I like
Well,
it. I like it.
The reason I
Points.
say that is because when I was at the VA, she had me collaborate it.
Okay,
And I
see,
had no idea what I was doing.
I feel like when I hear collaborate, I feel like we're rapping or something. you know?
Right?
But you're not wrong. You're just using the wrong word.
Oh.
Calibrate.
Calibrate, yes, yes.
There you go. Now you're right. Okay. So it is. It's used for calibrating, right, your devices. Because these devices, the whole point, right, is we're supposed to measure a volume and a flow. And how do we know if it's even accurate? So you have to have a way to make sure that the device is calibrated correctly and working. So this is the device that we are going to use and you guys can practice with, okay? So remember, right, and we'll get into this more next week, but 3 liters becomes important, right? You know this is made with that amount of volume. So if you push it in like you're supposed to with your device and you get 3.5, where did that extra volume, right? Or you get 2.5, where did that extra volume go to, right? And so that's what's going to alert you to issues, okay? And you will have some basic questions, not a lot, but you will have some questions on calibrating, making sure the equipment's clean, right? And stuff like that. So you'll get all that. But that's the first thing that you kind of have to know, okay? So used for calibration, super syringe has 3 liters, okay? This is called a respirometer, okay? And so this is going to lead into a little side conversation, okay? So what this is, it's a bedside device where you can measure tidal volume, okay? You can see it's got numbers right here, right? Okay, which you guys will get a try probably again next week. You'll get a bacteria filter. You guys will blow onto this and you'll measure how much, if you just measure one breath, right, in and out, that, what does that tell you? If you're sitting at rest, you put this on, you breathe in and out, and then you look at it. What does that tell you? Tidal volume, right? Respirometer.
Okay, so here's Kaiser.
Okay, now, my favorite calculation that I always like to talk to you guys about multiple times, minute ventilation, okay? Minute ventilation equals tidal volume times respiratory rate. Okay, so keep that definition in mind, that equation in mind. Now, what if I brought this to my patient, right, this little respirometer device. Now I have them make a seal and they breathe into it at rest, nice and comfortably for 1 minute. What am I calculating then? Well, you're going to count respiratory rate, whatever they breathe in a minute, but what about what number is building up on here? What is that? The minute ventilation, right? Because we said 1 breath was tidal volume. So if we have them just keep breathing for a minute, that's going to be their minute ventilation, okay? So I want you guys just to kind of drive this point home a little bit, okay? So normal, okay, normal, and now we're just throwing averages, okay? Just what you see in the textbooks and stuff. Normal tidal volume is typically around 500 mLs, okay? You have to make this distinction now though, okay? Tidal volume is always written in milliliters, okay? Minute ventilation is always going to be written in liters per minute. Okay, so sometimes that confuses students a little bit, okay? But we'll do something to kind of work on that, okay? Okay, so normal average tidal volume, 500. Normal range, okay, I'm going to give you 2 ranges for normal for minute ventilation, okay? A normal minute ventilation for a spontaneously breathing person like you and me, okay? 5 to 7 liters per minute. Okay. The one that you also need to be aware of, okay, so that's a healthy, normal person, 5 to 7 breathing on their own, okay? Normal for what we have to know for board exam, you want to write down the range 5 to 10 liters per minute.
So second group, so February 1st is when they're going to require those people who are doing clinicals. You guys are not going to get clinicals just yet.
Okay, everyone good with that?
We have time for that.
Okay, so now let's talk about that range though, okay? So minute ventilation, right, is basically what your body needs to do, right, to maintain life, right? Most of it you don't think about, right? We breathe normally at rest, right, because body doesn't need much, right? Okay, so when we think of minute ventilation, okay, we want to try to hit that 5 to 10 range, okay? That means that we're meeting our body's metabolic needs. We're getting in enough oxygen, we're hopefully getting out enough CO2, okay? When we're below 5, that's called hypoventilation, okay? And so what does that mean? What's happening in our body if we think of getting oxygen in, getting CO2 out? If we're hypoventilating, what's happening there?
The CO2 is increasing.
CO2 is going to increase because we're not getting enough out, right? We're not replacing that old gas with fresh gas because we're hypoventilating, okay? Now, what if above 10? What do you think that one's called then?
Hyperventilating.
Hyperventilating. Now, with that in mind, are we getting rid of CO2? We are, right? We're breathing deep and fast. We're hyperventilating. We're overventilating, right? So your body's still working, right? Gas exchange is still taking place when you're hyperventilating. It's just something is stimulating you, right, to increase that rate or depth more than what you normally would, okay? So the concern, and we're going to look at these in a little more detail, I just want to throw those out there for now, okay? The concern when we're hyperventilating is that you're breathing deeper, faster than normal, which means that you're using other muscles than you normally use, okay? So you're using accessory muscles, right, to develop this pattern, right, or to do this pattern. And so what the concern is when our minute ventilation is higher than 10 is that your patient is eventually going to tire out, okay? And so if they get tired, then they go from hyperventilating back to hypoventilating, okay? And now what I want you guys to work out, just to write down some calculations so you can kind of see hypoventilation a couple different ways, okay? We said minute ventilation, normal what we're looking for, 5 to 10, okay? So let's see the first example of hypoventilation that you guys need to be able to recognize is when we're moving a normal amount of air, but we're breathing too slow, okay? So minute ventilation equals tidal volume times respiratory rate, okay? So write down a tidal volume 500 and multiply it by a respiratory rate of 3. And tell me what your minute ventilation is.
500 times 3?
Yeah. So remember, tidal volume is always milliliters, right? So it would be 0.5. And then that should give you your final answer in liters per minute.
Oh, time already?
No, not yet.
Oh, when you gotta do
I'll let
it.
you guys know.
So this would just, since it's milliliters, you
Okay,
point
who's
the
going to
decimal
Kaiser?
before the 5,
Okay, so Kaiser.
and then your answer will be liters. So what'd you guys get?
1.5.
1.5 liters per minute. Is that gonna cut it? No, right? We said 5 was the minimum, right? Okay, so that's the first way. Your patient can be moving a normal amount of volume, they're just not breathing enough, okay? Second way you can have hypoventilation, which you're probably gonna see more often, okay? Respiratory rate is now 30, your tidal volume is now 50. Tell me what your minute ventilation is.
So this quiz is what you'll use, you'll answer with the Kaiser packet at this time. Okay? Alright, so Kaiser students.
So this one, when we said 500 was 0.5,
And you.
right? So 50 would be 0.05, right?
Next week. Anybody going to Madeira?
0.15?
Okay.
0.15?
St. Agnes.
Yeah.
Anybody going to St. Agnes?
What are those ties to?
Yeah, next semester. Alright.
It can, yeah, because
Okay.
those acid blood-based stuff, that's all a result of the breathing patterns, okay? So what did everyone calculate? The last group told me it was the same thing, 1.5. I didn't actually do the math.
1.5.
So print this out.
It's still low, right? So that's the point I'm trying to make is that you can move a lot of volume very slowly, or you can be moving a very small amount of volume very quickly and still be hypoventilating, okay? Because what happens, right, is your patient's usually huffing and puffing, using those accessory muscles, and then they start to tire out. They're still going to be trying to breathe though, okay? It's just they start to breathe fast and shallow, and fast and shallow breathing pattern still equals CO2 building up because you're not replacing that gas, okay? So those are two different examples that you guys can calculate. One, your patient just stopped breathing enough, right? Their respiratory rate just got lower and lower and lower. Other one, respiratory rate went up, but the amount of volume they were moving got lower because they were tiring out, okay? And so those are two ways that you can see hypoventilation and know that your patient's having issues. You can measure it at the bedside with one of these. Okay, and that's why you got to know about this. Nowadays, a lot of places you can measure all this stuff, usually with your advanced devices now, okay? But you still get tested on this, so you kind of have to know the purpose of it, okay? Next week, when we come in and kind of touch all this stuff, you guys can measure your own, or your partners, whatever, you guys can play with it, okay? These devices are spirometry devices, And so, this one would just be something you might see at a lab or at the, PFT office. And essentially, it's gonna have a graphic, interface right here, you put in your information, and then you do your testing by blowing through here, okay, and that's the sensor. They do hook up to printers and stuff, right, so you can print it out. Nowadays, right, everything's electronic and stuff, so you usually just get a
Okay,
transfer
so,
to the record.
remember, everybody's gonna have a case on your time loss?
A little bit older, but more typical, like what you would have in any department. If you had to do a bedside spirometry test for a patient, you come in here, put a mouthpiece here, do the same thing that you guys are gonna be working on in coaching, just at the bedside. And so electronically, and then you see your results right there as well.
So,
Um,
just, I wanna make sure that everybody understands, like, all the different skills that are available. So we have
What is
airway
this?
care, right?
Talked about this yet in any
We do a
process?
lot of airway care lab.
It's a peak flow meter,
Okay.
peak flow meter.
So peak flow meter, okay? And when we think of flows, we blow into this, right? And so this is called peak expiratory flow meter, okay? Now, this is a very simple way to get that number, or to get an idea of what that looks like, okay? Your spirometry devices will measure the same number, but a little more accurate,
Different types of
okay? And
modes.
we'll look at that in a second.
These are all your floor therapies right here.
This is for what's called a MIP,
Those are more of like
or a NIP.
hyperventilation.
So maximum
That's all really
inspiratory
specific based
pressure,
on what the hospital has.
negative inspiratory force.
There's an
So
other-
what we're
I'm
looking
gonna
for
add
with
the
this
rest.
one
I don't have the rest.
is basically for muscle strength.
So if there's
okay.
anything that I need to
And
add,
so
let
what
me
you
know,
would
'cause I can
do
modify it.
with this right here, right, it's just a pressure gauge, okay? But this would either connect to your ET tube, or if the patient was not
You
intubated,
guys can talk
they'd
about
put it in their
like,
mouth, and you would cover this hole, or they would cover the hole, and you'd have them breathe in as hard as they can, okay? And what we're looking for is basically, if you just want one number to remember for now, negative 20 is critical, okay? So meaning, and when we think about this, right, I'm breathing in,
and then remember.
so when I'm breathing in, it's making it negative, right? I'm sucking in, right? So if they can't even get it to go to negative 20, that means that they're critically not strong enough to probably move enough volume, okay, with every breath. Okay,
What
so
was that called again?
this, well, the test is MIP, MIP.
MIP.
This, I mean, honestly, I don't think they call this anything fancy. I think it's just pressure manometer.
Okay.
But it's supposed to go like negative and positive, so. But negative 20 is the cutoff, okay? I think they tell you in your book, like usually it's like negative 40 to 80 or more, which is normal, okay? So, but the cutoff, like one number you have to remember, just remember the negative 20. If they can't do that, then they're probably gonna need some assistance with breathing, okay? We use this both directions, okay? So when you think of, have you guys heard of like myasthenia gravis or Guillain-Barré? Okay, so these are like neuromuscular diseases, right? Do you guys remember how they work at all?
Weakness from the head down or the feet up.
Which one's which?
Oh, yeah. That was the other day. Yeah, myasthenia gravis is from the feet up.
Yeah. So the way to think about it, right, like is think of the letters myasthenia gravis.
From
So
ground to
M,
brain.
mine